Welcome to another episode of Le Coin des Experts. Today I'm very honored to have with us Dr. Jason Hawrelak. Dr. Jason Hawrelak is a researcher, educator, Western herbalist, and naturopath with 20 years experience. He did his PhD examining the capacity of probiotics, prebiotics, and herbal medicines to modify the gastrointestinal tract microbiota, and teaches worldwide on the topics of microbiota optimization and gut health. Dr. Hawrelak is Chief Research Officer at probioticadvisor.com, and he also established the Microbiome Restoration Center, an online educational center devoted to training health professionals to become microbiome clinicians. In this interview, we talk about definition of pro and prebiotics, red flags when buying a probiotic, some of the clinical applications of probiotics, reliability of metagenomics tests available today, ketogenic diets and the impact on our microbiome, implications of a long-term low FODMAP diet, SIBO and use of probiotics, and of course Jason's take-home message. As a reminder, everything that is discussed in this interview does not intend to diagnose or treat a medical condition, so please ask your healthcare practitioner before implementing any new treatment. Good morning or good evening, everyone, and I had the pleasure and honor today to be with Dr. Jason Hawrelak. Thank you for being with us today, Jason. Welcome.
You're very, very welcome. I'm happy to be here. Always enjoy talking microbiome and gut health and probiotics and prebiotics. It's like what I do 5 days a week, every day. So I'm
Every
pretty
day and
all day. Yeah, I'm pretty used to it and I enjoy it.
Thank you, Jason. It's a real pleasure because today you are going to talk to European audience. So this video interview is going to be translated into French and Italian. So we're
Okay,
very,
great.
very lucky. We are very
Yeah, because
lucky
my je parle un peu en français and very, very poorly. So I think if I was trying to be native French, it would be, I think your listeners would give up on me, but I can say very basic things. Yeah. But it's funny, my youngest daughter is like learning Italian now, and her Italian is very good in terms of her pronunciation. So I'm
that's
excited
awesome.
to next time. Yeah, next time we go to Italy, she'll be our designated speaker for our family.
That's awesome.
Yeah.
That's awesome news. But so let's get started because I'm interested. I'm curious to know how you got interested at the very beginning into the microbiome and the world of probiotics. What happened?
Yeah, so I was in the last bit of my naturopathic training. So I trained to be a naturopath here in Australia. It was a 4-year university degree. And last semester of my 4th year, one of my lecturers gave a talk around dysbiosis and the role of dysbiosis in disease. This was back in 1999. And some of you listeners will be surprised that we were talking about the microbiome and dysbiosis back then. Some of you won't, because it's actually been discussed for a long time by naturopaths and nutritionists and integrative doctors. But I just got so excited by this area of gut bacteria and how they might be related to all these different conditions. And this was back where we didn't actually know nearly as much as what we subsequently have learned. So I went and approached him right after his lecture and said, "Hey, I really want to do my honors degree in this." And then that started off doing a clinical trial of prebiotics, probiotics, and herbal medicines to modify the microbiome in patients with irritable bowel syndrome. We chose a condition that at that time, we knew that irritable bowel syndrome had a dysbiosis as a driver. We knew inflammatory bowel disease had dysbiosis as a driver. There's a few conditions that we were consistent with dysbiosis as a causative agent, and then nowhere near as much as now, where we can list 100 different diseases with dysbiosis as a driver. But back then, it was these gut conditions. Right? Okay, we'll choose this condition. We'll do some microbiome testing, as limited as they were back then. We're going to give them a combination of prebiotics, probiotics, and herbs, and see the impact. And then that grew into my 1 year's honors clinical trial and honors degree, flowed into a PhD that I did after that. And I think I just, stayed. I'm still equally passionate now, I would say, that what I was back in 1999 when I first started reading my, all these papers from honors thesis. And I think it just really blew my mind, the stuff around probiotics. I'd never even really heard of prebiotics, despite the fact I was, being trained in nutrition and naturopathy. Prebiotics weren't really on the radar at that juncture in
Okay.
research. They were, but not really discussed by clinicians or my teachers. And it's like, whoa, what these amazing things that can cause you some really phenomenal changes to the microbiome, and nobody's talking about them. And also learning all this new information about probiotics that was, well and truly beyond what I was taught. Soon after digging into the literature, and I was like, okay, I need to start sharing this information. So I started teaching at Southern Cross University, where my alma mater, where I studied, and I started teaching some undergrad students in the nutrition sections around probiotics and prebiotics and the microbiome. And that started probably 2000, 2001. And it kind of grew from there. And I've kept teaching on those areas since that
Wow.
time point, and kept learning on those areas since that time
Yeah.
point.
Thank you. You are our precursor. Thanks for being here and for doing what you're doing, because you're leading the way, you're leading the path, really. Thank you so much. Can you give us a quick definition, maybe, of just reminding what probiotics are and maybe what prebiotics are?
Yeah. Probiotics, I think most of us have at least an idea. We use the term, and most people, oh yeah, they have some conception of what that is. So it's live microbes that, when administered in adequate amounts, confer a health benefit. That's like the medical sort of definition that we tend to use. And there's a few bits of that. There's live, so the microbes have to be alive, otherwise it can't be really a probiotic. And they have to have a therapeutic effect when given, I think, is the other aspect. So some people would refer to some probiotic supplements as microbial mixtures or something, rather than using the term probiotic. Some people are really, you know, religious, maybe, but things, only certain supplements will meet the definition of probiotic, because you have to have human clinical trials showing that they're beneficial to take. That's kind of more the extreme end, but I can understand the rationale behind it. But yeah, essentially live microbes that, when you take it, they make you healthier in some way. Prebiotics is one of those terms that I think is very misunderstood and misused by the public and by clinicians too. Some people think any fiber is a prebiotic, and anything that feeds the microbiome it's a prebiotic, and that's totally not true. Prebiotics are
Okay.
selectively fermented, and it's the selectivity that makes them unique. Yeah, and different from just fibers or polyphenols that I think are all lovely things that nurture a wide range of microbes in the gut, and I'm totally into all those things. But the prebiotics, you have this very selective impact on the ecosystem. Like you can take a person or a group of people in studies and go, hey, they've got low bifidobacteria. We will give them lactulose or inulin fructooligosaccharides, and we see bifidobacteria go up. It's this very clear response. And there might be some small changes in other populations, but the really big change is increase of that population, or increase of Akkermans, or increase of Faecalibacterium. So they allow us to have a bit more nuanced and targeted approach to altering the ecosystem. Yeah. Whereas just having fibers or pectins and gums and resistant starches feed a wider number of microbes. And that's not at all a bad thing. It's just a different thing than what prebiotics do.
So not all fiber has, of course, an impact on the microbiome. So yeah, although
Well,
fiber
you'd
is
say
good.
that, yeah,
Yeah.
you'd say they would have impact, but they're not, maybe they might feed 10 or 15 different species or 20 different species, which again is not a bad thing. It's just a different thing. If
Mhm.
if I have a patient who's taken antibiotics, or even something like berberine, and it's really smashed down their bifidobacteria, I want to feed their bifidobacteria back up. And if I just say take some general fibers, the impact will be relatively small. But if I give lactulose or inulin phos or galactooligosaccharides, the bifidobacteria will come up really quickly, really directly, and we can restore those populations that may have been hit or hammered by antibiotics or even natural things like berberine.
No, that's awesome. Yeah, and actually, I will think about asking you this question later, but since you're bringing it up. So if someone takes antibiotics, let's say for 7, 10 days,
Yep.
what is the research telling us? Are we killing everything and everyone, or what's the situation? What's the aftermath?
Yeah, it depends a bit on the antibiotic is probably the best answer for that. And we in early 2000s did a systematic review of the impact of antibiotics on the microbiome, where we grabbed every single study published in the 1960s, 70s, 80s, 90s, early 2000s. It was a huge document, which we never got published because it was just too big, looking at the impact. And I remember creating all these tables. It was like a massive document, looking at the impact. And based on old style technology, the impact seemed to be mild to moderate. Yeah, depending on the antibiotic, maybe, within a week, 2 weeks, 6 weeks later, it seemed to be kind of restored, with the technology we used back in the 1990s and earlier. But when we switched over to using modern technology, DNA-based technology, we saw that the impact of antibiotics was far, far greater and far longer lasting, and we get extinction level events not uncommonly. There's a study published in Gut, the journal Gut, a couple of years ago, 9 species extinct from one course of antibiotics. 9 gone, permanently finished from the ecosystem. And you see that amazing, massive disruption initially. It's it's massively different. And then it does settle by about 4 to 6 weeks after the antibiotic, it does settle into a new pattern that's different, permanently different than it was beforehand. Yeah, you'll never get the same microbiome picture back after a course of antibiotics. Not all of them will cause mass extinction events. Some will have a smaller impact. Some will have substantively more. If you do antibiotic combinations, where you do 1, 2 or 3 or 4 antibiotics at once, the impact is huge, and you get phenomenal levels of extinction level events that are far greater. And I think it's vital for us as consumers and as clinicians to be aware of the impacts of antibiotics in such a phenomenal way, because it's imperative that we are judicious users of antibiotics. We don't take antibiotics because we have a viral infection or because the doctor thinks it might help some random things. Yeah, exactly. Because sometimes they're like, oh, we'll give the antibiotics just in case. It's like, no. It's like these will not just cause short-term harm like diarrhea. It's like this is going to be permanently alter my microbiome. And that's fine if it's like a life-threatening infection. No worries. I'm going to do the antibiotics, but not for a viral lung infection. I'm not, So it's imperative that we have that knowledge about the more permanent impacts on the microbiome get out there, so people can be more cautious and just use the antibiotics when they're actually needed, not just randomly for things they're not going to work for anyway. Yeah.
And it is, of course, very common. Even at the chemist, they give you, a packet of, probiotics with your antibiotics and say, okay, at the end of your course on antibiotics, you take this and you'll be fine, right? But yeah,
yeah, and that's better than not for the most part. But and I'd say that's an advancement to what they do in Australia, where they generally don't even do that. Or in the past, no one would have done that on the radar. So I think in Europe, they're further ahead that way. But I think it's still a lack of understanding of what the impact is. If you think that you can just take some probiotics, eat some sauerkraut, and drink some kefir, and your gut will go back to normal, it go back to what it was. It's wrong. We know that these microbes that we take as supplements or in fermented foods are not permanent colonizers. They're temporary visitors that can be helpful, immensely helpful, but they can't take up the same niche that we may have killed off. So if we take a course of antibiotics that kills off, 2 species of butyrate-producing species bacteria in our gut, we can't shove some lactobacilli in there and go, hey, it's going to do the same thing, because it can't. It doesn't have the same metabolic machinery to produce butyrate. So if we kill off our butyrate producers, we can't eat kefir and our way through it. They're gone. Yeah, so I think sometimes that conception that we've had kind of cheapens the microbiome, that we're like, we can just take a probiotic or eat some sauerkraut and our gut will reseed our gut. And it's one, it's not real. And 2, it just leads to, I think, these sort of problematic views that the microbiome is kind of easily replaceable. Because it's not, or that those kind of agents are temporarily harmful. It's like, no, they're actually arguably permanently harmful, and there are consequences. We know that antibiotic use in childhood leads to increased risk of obesity and diabetes. Antibiotic use anywhere for any age increases the risk of anxiety and depression. Studies showing that women in their 50s, if they took cumulatively 2 months worth of antibiotics, all up in their 50s, their brain age, they lose like 4 years of cognitive capacity later on in life. It's like the antibiotics have impacts because they're killing bits of us. And again, that doesn't mean we don't use them when our fingers about to fall off from infection or we're life-threatening. We do. but we just should not use them as flippantly as we do now.
Random. Yeah, yeah.
Yeah.
And so on the other side, so what are the clinical applications of probiotics nowadays? There's a immense study, a lot of research, and
Yeah.
you're contributing to some of this research, of course. So tell us about the clinical applications, how to use, when to use probiotics.
Yeah, and that's changed a lot too. Because again, you go back 25 years, it was like antibiotics, irritable bowel syndrome, ulcerative colitis, candida, thrush. These are the things that we're using probiotics for. You fast forward now, it's like, oh, low immunity, recurrent infections, Helicobacter pylori eradication, reflux, prevention of urinary tract infections, cervical dysplasia, prevention of obesity, postpartum obesity, prevention of eczema, treatment of asthma, treatment of hay fever, fatty liver, anxiety, depression,
You name it.
diabetes,
Everything.
gestational diabetes, endometriosis. It's like SIBO, food allergies. It's just like, it's huge. Yeah, it's changed a lot because of the amount of research that's essentially been done over the last 25 years predominantly. There was research before that time, as I said, mostly looking at gut conditions. And the first study in probiotics and IBS happened in 1958, 1956 actually. So we have been researching probiotics for a long time, but it's just really boomed from probably 2000 onwards, and moving beyond just gut. Yeah, like the first study was published in the late 1999, where they found if a woman during pregnancy took L-rhamnosus GG as a probiotic, it prevented eczema in the offspring. That was like a pivotal paper. That was like the first paper that showed probiotics did something besides gut. It's actually prevented an allergic disease. That was
Wow.
pivotal because that, again,
It
just
was
blew people's minds and
99.
like, yeah, that's right.
Yeah. So we know that now probiotics can help in so many conditions. So the way we use them, rather than just giving random strains and types of probiotics to anyone. So
Yeah.
how do we use them now? So what is the a better way of prescribing and taking probiotics?
Yeah, and I think that's totally evolved too, because we're kind of using probiotics as a therapeutic agent with a specific action. And just like, I suppose I'm a herbalist too. So if I have, someone who has depression or anxiety, I want to give a herb that relieves depression and improves anxiety. I'm not going to use a herb that decreases blood pressure necessarily, or
Right.
that gets rid of, period pain. It's not like, but I'm using the right herb with the right action. We know it's the same with probiotics too, that they have specific actions and attributes. So we kind of match it up of going, okay, this strain has been shown to reduce anxiety. Doesn't mean every probiotic reduces anxiety, because they clearly don't, but some do. And some treat depression, and some treat irritable bowel syndrome, but a lot don't work for IBS. So you're actually matching the strains that work for the condition we're trying to treat. Yeah, and I think this is, again, what's evolved over that time period. Because in the old days, it was like, we didn't have nearly as much research. We're like, just take a probiotic, whereas now it's like, no, you take the probiotic that has the action that you're after. Yeah, so we even with antibiotics, we know that if you take the wrong probiotic with antibiotics, it might actually slow down the restoration of your gut ecosystem and actually impair healing of your gut after antibiotics. When you take the right one, it'll actually speed resolution of any inflammation or microbiome harm caused by the antibiotic, and prevent the level of damage and prevent side effects from the antibiotics. It's a great scenario, but if you just use a random one, there's a chance of actually causing harm to that patient. So it's really behooves us as clinicians and consumers of probiotics to make sure we're actually matching the probiotic with the action we're trying to achieve, or the disease we're trying to treat.
But this is awesome. Thank you, Jason, for clarifying this concept. And I think it's quite revolutionary, right? And even within the manufacturing companies, are they following these new kind of guidelines, do you think? Or because we still see probiotics, with a lot of different, strains, like, 15, 10, 20 types of different probiotics in one, single packet. So where are we going, and what do you think?
I think it's mixed. There'll be certain companies that are all over this, and selecting their if they do a multi-strain preparation, they'll do it well. Yeah, they might go, okay, I want to I want to have a metabolic syndrome probiotic, I will choose one that's got research for fatty liver, one that lowers cholesterol, one that improves blood sugar control. So there's be some people really on it and they can make a really
Right.
potent multi-strain probiotic. And there's others who just shove the cheapest
Just
probiotic strains they can buy, show it in their
everything under the
supplement, and
sun.
then promote it for everything. Yeah. So
Okay.
it is quite varying, but I think there's a lot of companies doing great research on their strains and showing that their efficacy. What's perhaps lagging is the ability to make label claims, so sometimes that won't be on the
Sure.
label. It can't
Yeah.
even be on the company's website, but we'll have clinical trials showing that this product is good for these applications. And I think it's sometimes how much evidence is enough evidence to show efficacy. For some people who do label claims or government regulators about what's allowed on labels are like, we want 20 clinical trials with 10,000 people each before we're going to say you're allowed to make a label claim. It's a bit of an exaggeration,
Yeah.
but it's pretty
That's a
similar.
very good.
Whereas if you have, 5 clinical trials on a few hundred people, they might go, that's not enough. But for us, that's enough for me. And I need it on
That's
my patient and it
something.
works, but they may not be allowed to make that label claim. So just keep
Okay.
in mind that what's on the label of the probiotic may not actually match the evidence base in either direction. There might be a great probiotic strain with preparation made with great care, intelligence, thought, using well-researched strains, and they can't even put on the label what it's actually good at doing due to government regulations. And then you have some really crap probiotic preparations that might put a lot of misinformation on their labeling and on their website that make bigger claims when it's got actually no evidence for doing anything. Yeah, so it is quite variable in
Yeah.
that regard. Yeah.
So some red flags when buying a probiotic, right? So what there should be at least on a label. For instance, if we're talking about, let's say, lactobacillus rhamnosus, is there something that should be specified or something
Yeah.
which shouldn't be missing? This is for
Yeah.
for the general public, but also for some practitioners, I think it's good.
Yeah, and I think it's the strain designation that's really vital to see it on labels and in materials from the company. And to me, it's always a red flag if that's not there. So the term strain is one of those terms that's also misused by people in the blogosphere, by companies selling products either knowingly or unknowingly. I'm not sure
What
sometimes.
is the strain? Tell us,
Yeah.
Jason.
So
Yes.
you might go Lactobacillus rhamnosus is the species. Yeah. So Lactobacillus is genus, rhamnosus is the species name. There's no strain there yet. What the strain is what comes after that. So it'd be Lactobacillus rhamnosus GG or Lactobacillus rhamnosus GR1 or LR34 or something like that. It's that strain designation that actually tells us what that strain is capable of doing, because then we can look at the research on that strain and go, okay, there's studies showing this strain does this application, this strain does that, and this can make it a massive difference. Like there's a couple of different strains of Lactobacillus reuteri. One is very good for constipation and preventing antibiotic-associated diarrhea. Okay,
Mhm.
and then another one is good for osteoporosis. Yeah, but they're the same
So very
species.
different.
Yeah, but very different applications. Yeah. Um, and we know that strains matter. We have enough studies now, and we have in vitro studies, animal studies, even a few human clinical trials showing that the strains matter. They're closely genetically speaking related. Lactobacillus rhamnosus is still Lactobacillus rhamnosus. They're going to have a certain amount of qualities in common, but there's enough differences that can determine whether something works or not for the condition we're trying to treat. That's the other key thing too. So if a company is like, oh, we're using a different strain of Lactobacillus rhamnosus, but it does the same thing as Rhamnosus GG or Rhamnosus GR1, that's a red flag. You go, no, you
No.
can't say that.
We
Just
need
because
to
you say it
know.
doesn't mean it's true. Yeah, we need the research. I'm just going to stick with the ones that actually use the real product that has the research on it.
Yeah. Okay. And is the quantity important? How many millions, billions, trillions?
Yeah, it is to a certain extent, but I think you're spot on in kind of what you're leading to here is that for some people and what some companies say is like all that matters is quantity, like 500 billion is better than 1 billion. It can be, but what matters more is using the right strain for the job. Yeah. So, and there's studies looking at this, like there was, a study that looking at probiotics for antibiotic-associated diarrhea in elder population. And in one trial, they gave 60 billion bacteria per day of 4 different strains. Did nothing, did not work. Another study, they gave 100 million bacteria, one strain, it worked beautifully. So it's not all about number of species there. It's not all about
Quantity.
numbers of bacteria. It's about minimum dose and being above the minimum dose for that strain. That's what matters. And in general, we see that about 1 billion CFU. Yeah. For some things, there is a dose response. Some things there's not. For some people, some conditions, we found out that actually a lower dose seems to work better than a higher dose. And other studies, it's like, okay, no, higher dose will work better. But it's key to we just use the right strain for the job, and the minimum dose is achieved. Yeah, in general, that's 1 billion CFU of each strain per dose. There are exceptions to this, like the lactose reuteri DSM-17938. Sorry about the weird naming, but that's from the BioGuy company from Sweden. It's all over the world. That one we know works because we've got dozens of clinical trials showing it works at 100 million CFU per day. So it works at a lower, tenfold lower dose than what we typically would see. So that one is fine to use at that dose because we have all these studies showing it works at that dose. But in general, we're after that 1 billion or above. And just because a product contains 10 strains and 100 billion CFU of microbes does not mean it's going to work better than a product that contains the right strain at 1 billion CFU.
Thank you. This is super important because, people think, oh, the more the better, quantity.
Yeah, exactly. And some companies have gone, that's their marketing. They're like, let's buy cheap strains so we can put more in there. And people will be bamboozled by its multi-strain in such high numbers, but they don't care about the research pedigree and whether the strains they've chosen have any efficacy for anything. Yeah, that's the trade-off. Because often, if you're a company designing a probiotic supplement, you can choose to buy really well-researched strains that are going to cost more, or you can buy strains that have no research showing they do anything, let even surviving in the gut to any length of time for very dirt cheap. And if you're trying to what you think people care about is just the more the better, some companies will just choose the cheap route because that will, they'll make more money off that. Yeah, because most people still bamboozled by the more strain, the higher numbers, the better concept.
And so the delivery system is important, I guess. And I remember, in the old times, we were thinking, okay, it has to be refrigerated so that they keep being alive. So nowadays we find quite a lot of probiotics on the market which do not need refrigeration, right? You were talking about buying Gaia. So how does it work, and are we making sure that they get delivered to the right spot in the digestive system? What do you think about that?
Essentially, the changes have kind of occurred for probably a couple of reasons. One is changes in technology and our capacity to store things in bottles or packaged blister packs that have evolved since 20, 30 years ago. But more importantly, it's been changes in our criteria for selection. So when researchers are like, okay, I want to develop a new probiotic strain or new product, they might go to, this is often the case, go to some healthy people's poo. They'll isolate out the lactobacilli or the bifidobacteria from that poo. Then they will put them through what I call like a probiotic obstacle course. And that's going, okay, does it survive gastric acid? Does it survive bile salts? Does it adhere to the gut? Does it produce antimicrobial compounds that are selectively acting? Does it modify, interact with the immune system in some way? And is it shelf stable? That's a criteria that was added probably in the mid-90s. It's like, let's see if we can find whether it meet all those other criteria, but also are shelf stable so we don't have to worry about refrigeration, that they will survive environmental conditions. So it makes it easier to get to people rather than having to refrigerate the entire journey from, where it's manufactured to the shop to the home. And that's what's going to change things now, because a lot of the probiotics that have come since the 1990s have got that as a basic criteria that before they do any other research on it, it meets those basic criteria. Then they do animal studies with it, in vitro studies and human trials, and then it eventually becomes commercialized. But at that point, we know it actually survives at room temperature quite okay. Or if the occasional strain doesn't, at least we clearly know that, and they will package it in such a way that and let us know that particular strain does need to be kept refrigerated. But that's relatively rare for modern probiotic strains. That would be the exception these days.
Okay, so that's awesome. Okay, so we can be reassured that we're buying we need to buy the right type of
Yeah.
probiotics, the right strains for the right for the different conditions, and of course buy a reputable company as well. I think there are
Yeah,
so
and I think that's the other thing that goes into the importance of strain on the labels. Yeah.
yeah
When there's been market basket surveys done all around the world where some scientists will go out and they'll buy all the probiotic products in that country and they will grow them out to see what's in them and see whether they meet their label claims in terms of species and in terms of counts. What they've consistently found over the last 20 plus years is the companies that don't list strains are the ones that are missing. Like they might contain no bacteria, they might contain a few bacteria, might contain the wrong bacteria. Whereas those companies that use the well-researched strains pretty much always meet their label claims. Yeah, in terms of the number of bacteria that are present and the right bugs being present. So that's
okay,
another way of kind of assuring. So in some respects, yes,
that's
reputable
a good
brands,
company.
you're kind
Yeah.
of guaranteed that if it's got the strain designation there, you can pretty much guarantee that they've tried hard to make a therapeutic product and to make sure the bugs survive. It's the ones that do not list strains, where they've taken cheap shortcuts along the way, or ignorant around the whole field of probiotics. Either way, it's not a good sign. Does
That's
not
kind
make you
of
want to use their
hiding something,
products.
right? So when
Yeah,
it's
exactly.
not clear. Yeah, it's not clear. Okay. Yeah, yeah. So let's have a chat about microbiome tests. So so are they reliable nowadays? What are the best tests we can do? Yeah, what's your advice on the microbiome
Yeah.
tests?
Yeah, and again, as someone who's been in the field for a long time, I've seen them change a lot. When I first started off, we were doing comprehensive digestive stool analyses that would tell us about four species of the gut ecosystem, and we were making clinical decisions based on E. coli, lactobacilli, bifidobacteria, and enterococci. That was
Yeah.
like it. Those are the four. And then a few years later, there's a test that brought up 12. We could look at 12 different species, and they use PCR instead of culturing. Um, so technology has advanced, and it means and tools that we have access to as clinicians and as the general public have advanced dramatically too. So now we actually have access to high quality, accurate scientific tools to assess the microbiome that we really did not have, 20 years ago. So yes, I think the DNA-based tests that we have access to, two of the broader sort of technologies, and sorry, it's going to be complex terminology here, but the shotgun metagenomic sequencing, which is arguably the best and most accurate way of assessing the microbiome. We can see, metabolic pathways, and we can see, and that allows us to get a feel for even what some microbes might be doing for us when they're not even named yet or haven't even been discovered as yet. And then you have 16S rRNA testing, which is a more lower cost point, but still gives us accurate information from the genus level. So, Bifidobacterium, Lactobacillus, Faecalibacterium, Akkermansia, Escherichia, like that kind of level data is accurate. And if we stay within that testing paradigm, then we can definitely see the consistency. You can take the same person, same diet, no change of anything, get them to do a poo sample every day. It's going to look very similar all those days. Yeah. So it is. And then we can give them intervention and we can see the change. Yeah. And one of the first companies that brought like cheap, accessible, microbiome testing to the world was Ubiome, who since went broke. But listen, for $50 or $100, sometimes they would do these specials for $50. You could buy these kits that would tell you about the entirety,
Yeah.
all the bacterial species of the ecosystem. And for me, it was mind blowing, practice changing. Because before then, my patients are paying when I would rarely order the test because of the cost, but $800 to tell me about 12 species of bacteria. That's where we're at
Right.
before Ubiome came.
Ridiculous.
Yeah, and also I'm like, oh my God, I'm seeing 300 species of bacteria for $50. It's just like amazing. And they were using, the right technology. It wasn't like they're skipping on technology. It's just that, things as technology improves, the costs come down. And that's why we can even do things like shotgun sequencing now, because the cost point still higher, but you're looking at $200-300 a pop instead of a couple $1,000 that it was not that long ago to that kind of
Yeah.
testing.
But it's thank you for specifying, for clarifying this concept, because especially here in France and Italy, I can see so many different types of what they call like stool test, microbiome
Yeah.
test, and sometimes they're not even that. Sometimes they're still culturing, right? So
Yes.
it's very
Yeah.
confusing for someone that has no I mean, they trust us, they trust clinicians,
Yeah.
and sometimes it's really very cheap and not really, they're not metagenomic. So
Yeah.
yeah, how
And
to
the culturing
navigate.
tests are like, we should not be using them for microbiome assessment. Like there'll still be always culturing will be useful from a broader microbiology field perspective. And maybe to see whether, how to kill different pathogens, but you grow that pathogen, you dump some herbs, antibiotics on it and see if it dies. Like that aspect will always be
Yeah,
clinically useful, but it's just is lacking the capacity to see, up to 90% of the microbes in your gut. We cannot culture, even using the best possible conditions, which we don't have when we do home stool kits. Yeah. So all the testing labs that are still using culturing can tell us so little about the ecosystem. They're really not worth
yeah,
using.
yeah.
And there's other tests that use PCR, which is definitely a much better technology, but also often limited in terms of what they tell us about. They might tell us about 30 species or 50 species, but not tell us about the other 250 that might be present,
Right.
and the balance of them in the ecosystem too. Because I think what I love about the shotgun testing or the 16S testing is we get to see the balance. You get to look at the entirety of it and go, okay, what's the like between the pro-inflammatory, anti-inflammatory ones? We get to see a whole range of species that right, like polyphenol transformers and the whole suite of butyrate producers that aren't really talked about by most PCR tests. So I
Yeah.
think, again, I rarely use PCR tests in my practice. It's always 16S or shotgun testing, because they tell me about diversity, they tell me about the richness of the ecosystem, and they look at the entirety of the ecosystem. And I think all those things are vital if you really want to properly ascertain the health of someone's microbiome.
Wonderful. Thank you. Thank you. That's awesome. And we're lucky because we can find both tests, especially 16S
Yeah.
in Europe pretty easily. So that's
Yes.
awesome. And shotgun is slowly, I think, is coming as well. So that's
Yeah.
awesome. So who should do a microbiome test, Jason? Would you recommend, of course, people have like digestive issues, but not just digestive issues, right? Well,
Yeah,
yeah,
for sure. And I think that's what's changed too, because our linking in of what the micro diseases that are caused by microbiome, the microbiome has increased dramatically again in that, last 20-year period, from just gut conditions to actually Alzheimer's disease, type 2 diabetes, obesity, fatty liver, autism, chronic fatigue syndrome, eczema, asthma, type 1 diabetes, type 2 diabetes, rheumatoid arthritis, Hashimoto's. And this is not Parkinson's, multiple sclerosis. This is not an exhaustive list. It's like
yeah.
almost every condition you can think of that we see as clinicians working in Western countries has essentially a microbiome link. And sometimes the microbiome is the main cause
The
of
main
that
one.
disease.
Yeah.
Sometimes it's just a major contributing factor, but not the main cause. So you
Yeah.
could make an argument that everybody with a chronic disease should get their microbiomes assessed. And I could definitely make that argument, because it does allow for individualized, nuanced treatments, even though in some respects we know what's required to achieve a healthy microbiome, broadly speaking. Yeah, so it's like eating more plants, eating more fiber, eating more polyphenols, having time in nature, um, eating more organic food. There's a bunch of stuff that we go across the board will make people's microbiomes healthier, but it's just allowing us to fine tune and use specific tools to achieve changes in certain areas more quickly when we do the microbiome assessment. Because you might go, okay, you've got early stage Alzheimer's, you've got really high levels of E. coli or Klebsiella in your gut, and we know that they're endotoxin is what's
That guy.
likely driving the Alzheimer's based on the recent research. So let's hit that hard rather than going, oh, let's just change your diet for a bit of time, which will over 6 months make a difference. Yes, but I'd rather just use some herbs and some prebiotics and bring it down within a couple of weeks, and then use the diet as a long-term ways of
Yeah.
keeping those bacteria
Yeah.
in check. So I think there are advantages for everyone to do the testing in terms of just the chance of individualized treatment to a greater degree, and to potentially move things
Absolutely.
along more quickly, even though, as I said, in some respects, some of the recommendations are generally across the board useful for everybody with every disease state. You would argue how to relate that we can see with improving diversity of the ecosystem, improving levels of butyrate producing species, reducing levels of pro-inflammatory proteobacteria. It's going to be stuff we do. It's pretty much across the board because research has shown that kind of maybe triad of sort of dysbiotic states is like a driver of Western chronic diseases that we see on a day-to-day basis.
And inflammation, as you were saying, all these inflammation and all these LPS producing bacteria, they're a major driver of inflammation. It can be not just gut inflammation, but systemic inflammation.
Totally systemic inflammation. Yeah, and we look at the research around Alzheimer's, like people with Alzheimer's, when they've done autopsies of their brains, they have between 2 and 26 times the amount of endotoxins in their brains compared to healthy controls. They look at the bloodstream of people with Alzheimer's and mild cognitive decline. They have 3 times the amount of endotoxin in their bloodstream compared to healthy age-matched controls. And we know exactly the impact of LPS causes neurofibrillary tangles and causes amyloid beta plaque to develop. It's very clear that this is a key thing. And that's just Alzheimer's, but it's linked in with cardiovascular disease risk. It's linked into metabolic dysfunction. All these things are driven by endotoxin, and I think it's really important that that concept itself gets out there more, because I think there's microbiome dysbiosis, but this one of the core drivers of essentially harm coming from the microbiome is endotoxin or lipopolysaccharide, and we really have to do our best to reduce numbers of the bacteria in the gut and prevent its absorption. That is key. That is key.
Yeah. So everybody actually should do a microbiome test in the life, or I would say everybody.
Yeah, and I think for most people, obviously in Western nations, can afford that. Most people can, because the price points are so low.
Yeah.
When I had to charge my patients with $800 a pop for the test, I was a little bit more picky about when I would definitely do one, or whether I'd make assumptions. Like, I'm going to assume you've got dysbiosis based on your symptoms or your disease state. We'll make some assumptions what's going on and treat you. But when that goes down to the $100, $200, $300 mark, it becomes like, no, we can actually look and we can make sure what the system looks like, and we can treat you.
Absolutely. It could be life-changing. It's a great way for disease prevention. Yeah, it's great. Yeah. So what are the good things and what are the less good things that may affect our microbiome in terms of habits, like food habits, maybe carnivore, or even the famous or unfamous low FODMAP diet, or what do you reckon, Jason?
Yeah, I think broadly speaking, whenever we restrict plant foods from the diet, there's microbiome harm. The degree of restriction in terms of how broad that is will dictate how much harm there is. So the carnivore is the extreme example of that, where we cut out everything that comes from plants, and this is where you get massive microbiome harm. You get substantial reductions in all beneficial bacteria, because they're all fiber consumers, and you have these blooms of protein putrefiers and bile acid eaters, which are pro-inflammatory species. That's very clear, the impact of the extreme end of things. We cut out all plants. And then you have intervening times of keto type diets. Well, that depends a bit on what your keto is. Is it like a plant type keto, where you're still having it's olive oil and it's nuts and seeds and olives and lots of green leafy things? That will have a quite different impact than the bacon, egg, lard, and dairy cream keto, which will cause, again, massive negative shifts in the microbiome, massive reductions in beneficial beef species, because we know that even ketone bodies themselves are toxic to bifidobacteria, for example. So there are an obvious drawback there, irrespective of the restriction of food sources, because I think keeping in mind that these things, what grows in your gut, what bacterial species grow, depends on what we feed them, and what we feed them depends on what we feed us. So if we're just eating meat and fat, we're just feeding microbes that eat meat and bile for the most part. And if we're eating fibers and oligosaccharides and polyphenols, we're feeding those that eat fiber, polyphenols, and oligosaccharides, etc., resistant starches. And we know those ones are the ones that produce butyrate, that produce healing anti-inflammatory compounds. Whereas those that putrefy protein or eat bile produce ammonia. They produce a range of toxic metabolites, p-cresol, for example, and hydrogen sulfide gas. And hydrogen sulfide gas, small amounts is fine, but larger amounts, which is what we have when you kind of feed those species, that eat sulfur amino acids and eat bile causes a range of issues, both locally in the gut and body wide. Because hydrogen sulfide gas is a mitochondrial toxin. It causes a leaky gut. It causes your nerves in your gut to become hypersensitive, called visceral hypersensitivity, which is very common in irritable bowel syndrome, for example, where the nerves you can feel little gas in severe cases. You can feel little gas bubbles making their way through your gut. And that is driven, there's a few causes of that, but hydrogen sulfide gas is one of the causes of that. And I see that commonly in practice in those patients who have elevated levels of hydrogen sulfide gas producers will have visceral hypersensitivity. Sometimes it takes a while to develop. And this is where I think the challenge can come in those people that have gone like a animal type keto or carnivore, is they're not going to feel that at first. That's going to take a few months before that actually builds up. Yeah. And a few months to really starve off enough of your good bacteria too. And it's those patients, I can say from, working with patients for 20 some years and seeing probably 15,000 patients, the ones who've been long-term carnivore are the hardest to get better, because their microbiomes are by far the worst. They're the most damaged, the most deficient in good gut bacteria, the richest and some more problematic ones. But the degree of visceral hypersensitivity is often so severe that any plant food, when you first bring it back in, any prebiotic fiber you bring in will cause them pain and discomfort, because the nerves just get triggered with a tiny little gas bubble. Now it's so severe. And it's hard because you have to do so much preparatory work to try to heal that before you can bring food back in for the microbes. So it's a really slow process. And that's one of the diets that I've got the biggest issue with as a clinician, because you just see the long-term harm from it. Like, again, a week on it, no, it's not really a big issue, but you do it long-term. The damage to the gut is hard to repair, and the damage to the microbiome, I would argue, at a certain point becomes almost impossible to repair without doing, fecal transplants, for example.
Wow. And we see this quite a lot, actually, as you just mentioned, because hydrogen sulfide gas. So we see in one type of SIBO as well, right? SIBO, or, colonic also, of course,
Yes.
presence of hydrogen sulfide. And definitely. So sensitivity, like visceral sensitivity, is pretty common.
Yeah.
Which is
It is with my patient cohort, because I've been working with, IBS patients for nearly 25 years. Because that was what my honors thesis was on and PhD was on. So my clinical practice has always had a huge gut focus because of that.
You're the world renowned, specialist. So of course, you have a lot of experience, and so you see a lot of SIBO. So SIBO patients, of course.
Yeah.
IMO, SIBO, and so probiotics, yes or no with SIBO? What's your
Definitely yes. Definitely yes. And sometimes it's always worthwhile trying to follow back the evidence and see where some ideas come from too. And some of the ideas of we shouldn't use probiotics in SIBO comes from, follow back, people who work for pharmaceutical companies making antibiotics. So it wouldn't be surprising if they're putting out ideas you shouldn't take probiotics because it's
no names
products.
here.
No names, and listen,
names.
it doesn't mean that there's other components too, but I think for me, because I was looking at all the research around IBS and probiotics, and I was using probiotics in my clinical trials, and I'd read every single study about probiotics in IBS, in the late 90s, early 2000s, when I was doing my research. And this idea came out that, okay, SIBO is a cause of IBS. That 80% of people, had IBS patients had SIBO. If that was true, then it makes sense that probiotics would work, because there's always been clinical trials from the 1950s showing that probiotics work in IBS. But then for someone saying no, probiotics don't work, was always like, it just doesn't make sense. If this condition is an underlying driver of IBS and the probiotics work in IBS, why would they? It's illogical to think they wouldn't work in SIBO. And also because I think for me, the idea of probiotics is always different than they just go in your gut and grow. It was like they produce antimicrobial compounds that reduce levels of pathogens. They can improve motility. They can change gas dynamics. Those were where my brain was coming from when this whole SIBO stuff blew up in like 2005, 2006. So it's like, for me, it's like, of course, probiotics are going to be helpful for this. And you look at some of the literature, even at that point, of kids who were hospitalized with severe life-threatening SIBO were treated with probiotics and they got better. And I thought, okay, so we've got that. These case studies showing dramatic improvements. It never made sense to me that why antibiotics or why probiotics shouldn't be used in SIBO. And again, you fast forward to where we're at now, you look at all the clinical studies, it's very clear they're helpful. It doesn't mean that every single SIBO patient will respond well to every single probiotic. No. And I don't think that they're a panacea that you can just use a probiotic for every patient and that'll cure their SIBO either. No. But I think the idea that we can't use them is based on old ideas and I think some industry push about where we should be going, which is obviously an antibiotic focus was one of the core drivers that originally came out with SIBO too, was like they had to use rifaximin. That's the only way of treating SIBO back in the old day. Yeah, so I think there was a vested interest that had an impact on how our cautiousness was around tools to use to treat SIBO too. Yeah. But yeah, I've do updates every year of research on probiotics and SIBO, and every year there's more and more studies showing they work. And they've been core part of my practice since I first started treating SIBO. And when I've worked with IBS patients, even before we know SIBO existed, I was always using probiotics as part of that too.
Yeah, you're right. We were all using probiotics and all the good things for IBS. So yeah, totally. Yeah. So again, using them, but knowing what you're using and for what type of maybe SIBO you're using them. So yeah, always with a think about the action. Yeah.
Yeah, that's right. Because I'm sure that if you gave the like a probiotic that reduces, like there's some probiotics that reduce high blood pressure, and if you give that one to SIBO, it's probably not going to be that helpful.
It probably won't work.
You want to use the ones that actually will target the overgrowth in some way or enhance motility in some way. It's like, yeah, we can definitely use probiotics for those tasks, but just choose the right one. And then don't use some random one because it's got some high numbers, because it may do absolutely nothing and might even contain what it's supposed to contain too. And that's
maybe like just to share one maybe that you like using for maybe methanogens overgrowth.
Yeah. I mean, I like the BioGaia lactose reuteri DSM 17938 for methane issues. I think because we have, again, clinical trials showing it works for constipation, it speeds up transit time, it softens stool, and we have studies showing it reduces methane output when people take it. Yeah, so I think we've got all that data, and it's usually well tolerated. Not every patient, will tolerate it beautifully, but it's often well tolerated, and I see it as a useful component of treatment protocols. Sometimes, with kids who are, maybe the herbs that I might typically use aren't going to be an option. I will just use pre and probiotics and have some good results in that population just with them. I think with adults generally will often need more than that, and the herbs often work well. But I have experimented with more tough to treat SIBO cases who haven't responded with herbs or emo cases with just mega doses of different probiotics and have had some good results too, where you see these massive reductions of breath gases just from using probiotics, the right ones and in relatively high amounts. Because when it's bacteria in the small bowel can more easily be outnumbered by a probiotic supplement. Yeah, in the colon, it's a different story where, 1 gram of poo is like, 10 to the 12 bacteria in there. It's hard to shift that much with a probiotic supplement. But in the small bowel, the numbers are often far less, and it's actually much easier to modify that population with probiotic supplements, essentially.
That's awesome. That's really great news. And do you have a favorite probiotic? Do you have any favorite one?
All my probably practice life, the one I've used the most for the most applications would be lactobacillus GG to LGG. And I think for probably a couple of reasons. One, it was probably the first of the sort of modern generation probiotics. And two, it's still like, I've got my probiotic advisor database, the probiotic with the most research studies on it on Earth, the most positive research studies for the most different disease states is LGG. It actually fills a whole page of different conditions it's been clinically trialed and shown useful for. It doesn't mean it's great for everything. It doesn't help with urinary tract infections, for example, or bacterial vaginosis. Yeah, no, not so much. But there's a bunch of things it's amazingly useful for. Yeah, antibiotics, for example, or viral gastroenteritis, which is something that we commonly have to deal with as if you have kids or if you have pediatrics component of your practice, and many other things too.
That's awesome. Yeah. And what else can we know? What else can we ask from you today, Jason? How can we become more knowledgeable into this amazing, world of probiotics, prebiotics, and microbiome manipulation? How can we study with you?
Yeah, and that's really why I've kind of moved from, I've taught in universities for a long time, to setting up my own sort of specifically centered courses on microbiome analyst course, naturopathic functional medicine approach to gastroenterology course, so I could actually really intensively train people and upskill them in these areas. Yeah, because I think we reached that point where we can no longer ignore the role of the microbiome in disease states that we're seeing. So it's imperative that we become like microbiome literate clinicians. Yeah, and that requires us to really upskill in I don't know what tests we can do, how to interpret those tests, and how to use a whole range of tools to modify the microbiome. And that's one of my key passions, is educating clinicians in that area, and also treating a range of gut conditions with the microbiome as a key component that you're always keeping in mind. Like for us, my institution is the Microbiome Restoration Center, where the microbiome comes first. It's our tagline, because I'm always thinking, okay, we could treat this infection or this condition by using these microbiome harming things, or we could use microbiota friendly things. That might seem like a no-brainer, but you have to know that this stuff here might cause harm, and you can choose other options. Yeah, so a lot of the focus is on training people and going, how can we use prebiotics, probiotics, selectively acting herbs to actually cause all the changes we want to see in a range of gut conditions, and always having that the microbiome is important. We don't want to kill it as a core underlying driver, because there's a lot of tools that even we have access to as people in the natural medicine world that can cause microbiome harm. Dietary protocols that can cause microbiome harm. It's imperative that we're upskilled so we know that. Yeah, because I think it's often not an intentional thing. It's a thing of ignorance, where people are causing microbiome harm because they don't know that the berberine they're giving, or the enteric-coated oregano oil, or the ketogenic diet they're prescribing, that variant is going to cause microbiome harm. They just don't know. So they're inadvertently causing harm to their patients. So I'm really trying to change that. So
we need to be more, well-trained clinicians. I think we need more of, of course, people, that train with you, and I can personally testify of that your courses are amazing. And you have a few courses. You have at least one more basic introductory course, and a more advanced level. And of course, other courses available. So this is all available online, so everybody can study from all over the world. So which is awesome. And what else would you like to share with us as maybe a take-home message for people listening to this interview?
I think my take-home message would just be to think of yourself as a custodian of your microbiome for future generations. Yeah, and I think when we sort of embrace that custodianship role, we know when we look after a family property or our property, or thinking that we're going to look after it so our grandkids and our great grandkids can enjoy this space. It's kind of like, for us, we're looking after our microbiomes. We can pass it on to our kids and grandkids, and they can have the microbes that they're really supposed to have. I suppose might be the way, because we know that with Westerners we are moving towards like a microbiome desert. With every generation we get less and less diverse ecosystems. And I think we're seeing the results of that everywhere we look in terms of chronic disease, is due to that sort of microbial desert that we're creating in our guts. So I think it's imperative that we're aware of the things that are causing microbiome harm, aware of the things that nurture and heal and optimize the microbiome. And we're doing it not just for our health, but for the health of our kids and our grandkids and our great grandkids, because the composition of the microbiota has changed so much in Westerners because of the Western sort of dietary protocols, the Western medications, lifestyle factors, high stress, not enough time in nature, so many things that we do wrong, or all the chemicals in our food that are causing microbiome harm, that we should try to minimize that as much as we can. But just not for our benefit, which is good enough, but I think it's also looking at our everyone else around us as a good rationale for preserving our microbes in our guts too.
No, thank you. That was an awesome take-home message, really, Jason, and an awesome interview altogether. I think everybody is going to love this interview, and maybe we'll have the pleasure of sharing more information maybe in the future with you again. Thank you again, Jason. It was really, really awesome.
You're welcome. A pleasure chatting with you.
Thank you.